So the structure of medical practice is that you get paid for what you do, and so you tend to do more of it. And
Yeah.
so it's the same thing as if you took your car in for a service and you said, "I'm not sure what it needs." They're going to do more. They're going to do everything. We better just do the tires while you're here, and the brakes look a bit worn. I'll change them, and they're going to do more probably than they need to. The main reason is because the doctors believe it to be effective. So there's this mismatch between the perceived effectiveness of medical procedures and the actual effectiveness. And this is this overestimation of benefit that doctors have. We think that everything we do must be helpful, and the more of it we do, the better. And so we think more medicine is better, when in fact it's not necessarily the case. And there's lots of movements that recognize.
Welcome to the Mixed Emotions podcast. This is your host, Mihir Oak. You are Dr. Ian. Am I pronouncing it right? Ian Harris. Is it pronounced Ian?
Yes.
Awesome. You have a scalpel in one hand and a mirror in the other. You quite literally are a clinical orthopedic surgeon. You're an author. You are a professor. You're an academician as well. You're a researcher. You're essentially a scientist
Yeah.
in the medicinal field. And you've written two books, which we will come to. One is Surgery, which is the ultimate placebo, and the second is Hypocrisy. And you're essentially
Yeah.
asking the question of not to us, but to your own community of the procedures that doctors perform. What is the benefit of it in terms of the actual procedure versus the hopeful benefit of it while getting through it? Dr. Ian, thank you so much for joining us on the Mixed Emotions podcast. Welcome.
My pleasure.
Thank you. How did you get interested in this question? What was your childhood like? What was your experience like that allowed you to question the system and also gave you conviction enough to pursue this theory of yours?
I always had a scientific bent. So I wanted to be a scientist. I became a doctor and then a surgeon.
Right.
When I started practice as an orthopedic surgeon, so when I was young, I always wanted to be a scientist. I ended up becoming a doctor, but I was always attracted to the scientific method. And I remember seeing, I talk about this in my first book, a documentary when I was about to start university. So I was still quite young. And it was a documentary where a local well-known scientist and an entrepreneur in Australia had invited James Randi, and some of your listeners may know who that is, but he's a famous debunker or skeptic of certain claims, and invited him to Australia. And they tested water diviners. And in Australia, water divining is very popular, and people pay water diviners money to come out onto their property to find where they can dig to find water.
Yeah.
Because in remote Australia, there's not so many rivers, and so you need to dig a hole to find water. And they got these water diviners and tested them, and the way they did it really struck a chord in my brain. And I thought, this is just so convincing, because they dug 10 separate pipes in the ground, ran them across the ground, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then buried them. And they said, we're going to run water through one of the pipes. You walk across all 10 pipes and you tell us which one has the water. Because they can't see it, but they know where the pipe is. And they tested it first, and they said, okay, now we're going to run the water through pipe number 3. And they got them to walk across, and all their equipment, their divining equipment, started activating after pipe 3. And they said, oh, yes, it's working very well, because they knew
That
the
it
water
would
was
come.
in pipe 3.
Yeah.
And then they did a blinded test, of course, randomly putting water through the pipes and asking them to walk across. And of course, their guesses as to where the water was no better than chance. And so basically proved to me then and there that water divining is rubbish. It doesn't work. And I remember just being so convinced by the methods, the scientific method, the blinding, the randomization, and how it created this very convincing evidence. So at the time, I wanted to be a scientist. But an interesting story, and the reason why I tell that particular story is because after I became a doctor and I realized I started operating on everything and I did all the operations that everybody else did because that's what we did. It wasn't very scientific. We didn't get
Right.
caught in the scientific method. I wanted to be a scientist. And so after I was an orthopedic surgeon for about 7 years, I started my scientific training. And I
Right.
did a master's of evidence-based medicine. I did a PhD in evidence-based medicine. And then when I was writing the book, because I realized that a lot of the things we do simply don't work. And when you put them to a scientific test where patients are blinded, the tests are objective, there's
Yeah.
no bias, we
Yeah.
find all of a sudden this operation doesn't work. And I went back and looked at that old 1980s documentary because you can get it on YouTube. And I
What is
watched
it
it
called?
again.
What is it called?
It's called James Randi in Australia,
Okay.
and you can get it on YouTube. And I watched it again, and of course I saw the methods, and there was no surprise there. But what struck me when I saw it the second time was the reaction of the water diviners when they were confronted with the evidence that water divining was no better than chance. And that's really struck me because what I saw was the same reaction in surgeons and doctors that I talk to when I tell them that their operation doesn't work, that the evidence has shown that it doesn't work. I get the same reaction, and it's like disbelief. And in this case, the water dividers were saying, "Oh, I think maybe there was some metal in the dirt that might have interfered with our reading." And another one was saying, "Oh, I think maybe there's been some sunspot activity which can interfere with it." And none of them believed the scientific results. They believed that it worked. And the reason they believed it worked is because for generations they have been finding water.
Yeah.
Wherever they dig, they find water. Now, those of you not familiar with Australia may not be aware that if you dig anywhere in Australia, you will find water. And James Randi was very clever. He said, the real test for your skill as a water diviner would be to go out to a property and tell us where to dig where we will not find water,
Mm.
because you will
Right.
not be able to do it. And so in causation terminology, they were not seeing the counterfactual. They were
Right.
just seeing one side of the argument. They weren't seeing the opposite side. And it's the same thing with the surgery. The reason why surgeons do operations that don't work is because they see people get better. But what they're not seeing is what would have happened to those people if they did not operate on them.
At all. Yeah.
And my argument is that they would have gotten better anyway.
Do you think though that you've said that surgery is a placebo? You use the term placebo. Now, placebo, to my opinion, is an effect, and it is not nothing. It is something is happening inside your mind because of something. It might not be scientific, but it still happens. Now, the point is that we don't know if it happens out of the words that we use or the actions that we do, or it happens from bodily process of not doing anything, and the body does it on its own.
We can work that out scientifically. The placebo effect is very confusing. And I think if I wrote another book today, I would describe it differently. The placebo effect I defined in my first book included natural history or what would happen anyway, whereas that's probably not precise. And in fact, by definition, placebos have no effect, because
Yes.
if they have an effect, they're not a placebo. So you can see how it becomes confusing. So what we have is what we call non-specific effects.
Okay.
So there's the specific effect of an operation, which may make you better. And there's the non-specific effects, which are made up of natural history, expectations, and other factors that may influence a patient's response to
Right.
the treatment. But we've done research on this more recently, and we published this, I think it's a couple of years ago. And we looked at studies in surgery where they had an active arm, a placebo arm, and a nothing arm, no treatment at all. And we found that even with no treatment, with nothing, it gives you about 2/3 of the effect of surgery. So 2/3 of the explanation of surgery is what would have happened anyway if you hadn't have done nothing at all.
Yes.
And what we found was no difference between the placebo group and the do nothing group.
Oh, all right.
Yeah, so that tells us that there is probably no placebo effect in surgery. And largely it's what would have happened anyway, or what we call the natural history.
That's fascinating, to be very honest, because that would go to show that it's just bias of belief of doing it again and again, and like a ritual of seeing that patients do get better from an act of surgery.
Yeah.
And
It's a lot.
yeah.
I was going to say there's a lot of bad research in the placebo literature. So a lot of people promote placebos as beneficial treatments. But when you look at those studies, they're very problematic. For example, there's been studies looking at long-term effects of placebo treatment for back pain. But what they've done is they've only followed up the group that got the placebo, not the group that didn't get the placebo. And they've said, 70% of our patients are still feeling very good 5 years later after receiving placebo. But they're not telling us that 70% of the people that didn't receive the placebo are probably feeling better as well. They only present one side of the study. So there's a bias in a lot of the placebo study reporting, which is problematic.
But also then goes to show what kind of questions you should be asking and how should you be creating research which is non-biased, which is non-partisan, which is not based on the answer that you would want to get versus
Yes.
more on the question that you want to ask.
Yes, exactly.
But then how, like, it's human beings, unfortunately, in the end, and human beings are emotional and they would want to.
Yeah, I always say that human beings are not naturally scientific.
Okay.
They're naturally biased. They naturally want to support their own beliefs and not be challenged. And so it's difficult to be scientific. But to be a good scientist, you have to set up your studies so that they are unbiased or as minimal risk of bias as you possibly can. And you need to be open-minded to possible results and possibly results that contradict your initial beliefs.
So review system may be third-party reviews or something.
So the studies we use, we often blind the patients. We blind the people who are doing the follow-up, so they don't know what patients are in. We blind the statisticians, so when they're doing the analysis, they can't play with the numbers to make it look better because they don't know which group is which.
Correct.
And so we randomize the allocation, so there's no influence over what treatment people get. And these are just the best ways of doing scientific studies. There's no perfect study, but certainly there's good and bad studies.
No, but I agree with the way that bias creeps in everything. It's not just medical and scientific research. It's also like I work for this tech company and there are software developers and there are software testers. And you cannot have the two in the same room. And you cannot have the developer testing his own code because there is an obvious bias in what he or she may have developed and so would be ignorant to the problems that arise from his own code. So they are kept in two different rooms. There can be no interaction between either of the two. And that is essentially to prevent a bias from occurring.
It's very interesting. Very interesting. Yeah.
It's pretty much goes on the same lines on anything that you would want a I don't know, I'm not getting the word for a synonym for bias, but like you would want an independent, neutral perspective
Yeah.
on things, and that is the best way to. That's how ideally democracy should also work. But yeah,
Yeah. Yeah.
um, but see, medicine is you're saying medicine is influenced by placebo, but placebo technically should not work. The pharma industry benefits a lot from the placebo effect, like painkillers in general. I can give you a lot of examples where painkillers, if they are made heavier, then people are more likely to get better. If they are branded, they're more likely to get better. If sleeping pills are made blue, they're more likely to be more effective. If
Yeah,
pain,
a
yeah,
lot of that research is not very good either. So if you look at the studies that looked at the color of the pills, there's one that says that the red pills do
yes,
something else. These are studies with, I think, like about a dozen people in
with
them,
an agenda,
of which sort of three got a red pill and three got a blue pill. These are terribly
yeah,
underpowered, weak studies. These are not very good studies that have been done. However, if there is an effect, the perceived cost might improve the effect in a subjective outcome like sleep or pain or something like that. It's because we are manipulating the patient's expectations and we are controlling the therapeutic envelope in which the therapy is provided. So that's things like the color of the pill, the attitude of the person that is prescribing it, all of these things. So people call these placebo effects, but I don't like to use the term placebo effect anymore. I'd say, no, that's the effect of the attitude of the person prescribing the pill. That's the effect of having a larger pill or something like that. It's not a placebo effect. And when these things have effects, they are very short-lived and very small. And when you
right.
look at the placebo research, it's, oh, if it's given by an enthusiastic practitioner, the effect is stronger statistically. You look at those studies and you find it's a very tiny bit stronger. And then after a few weeks, there's no difference. So these effects are really not useful clinical effects, would be my argument.
Have you come across any partner, any surgeon, any medical practitioner that accepts the placebo effect or accepts external effects and goes to say that now that we know that there is an effect, might as well that be combined with the act of surgery itself, because maybe the effect is coming from the act of going ahead with the procedure, and that is what makes it more effective. How would you counter that?
Yeah, I think everybody does that. And I don't know how effective it is. But for example, everybody wants to give the most professional looking, authoritative, for surgeons,
Confident, yes.
decisive, confident, and they want to set expectations of the patient at the right level, don't set their expectations too high. And so I think this is not just surgeons or doctors, it's physiotherapists who do it. They spend a lot of time hands on the patient. So the interaction between the therapist, getting their confidence, making the patient feel assured that they are in good hands. So these things possibly have an effect. And I think we all use those things because it seems to help. But it depends on what you're treating. If you're treating maybe an anxious patient with a not really a physical incapacity, then it may be quite effective to make them feel at ease and feel like they're being cared for and confident that they're going to get better. They may say that they feel better. So I think we all tend to do that, but I just don't know how to really quantify it because it does depend on what you're treating. So if I'm treating somebody with one leg that's shorter than the other, no amount of being nice to them will make
Yeah.
them walk evenly. But once I've evened their leg lengths, they will walk much better. So it depends on what you're
Treating.
treating.
Yeah. But more likely than not, physical, like actually reconstructing joints or making bones become better would be more on the physical side of the mathematics side of medicine, of actually showing proof that surgery and taking action would help versus belief that it would help.
Yeah, so some people say I'm very anti-surgery. I'm not really. I'm just pro-science. So many of the operations we do are effective, and these are often the operations like somebody with terrible pain from arthritis or the knee. If we remove the painful joint and replace it with an artificial smooth joint, their mobility improves, their pain decreases, their ability to walk unaided is improved. And these have been shown in randomized trials to be highly effective. So you probably don't need to try and work on some kind of contextual effect, which is another name
Right.
for placebo effect. But still we do it because there's still cases where patients can have, say, a knee replacement for their arthritis, but they're still not very happy afterwards. And often patients will still have pain in the knee,
Yeah.
maybe not as much as before, but they'll still have some pain in the knee. And if they're not in a good mental state, they may dwell on that pain. And then they may, if they had a bad experience with the doctor or had an argument with the doctor, then they might start to blame the doctor for their ongoing pain. And their
Right.
concentration on that pain may actually magnify their perception of the pain. And we get into lots of psychological problems. And now all of a sudden we have a miserable patient who's blaming the doctor for their ongoing pain and suing them and things. So we still play this game of trying to make sure the patient is comfortable that they are being treated well and
Yeah.
appropriately.
Can stress lead to bone problems, bone health problems?
I'm not aware of any evidence that it can. The bone problems that I treat, like arthritis, fractures, deformities, almost always purely physical phenomena.
Structures. Yeah.
Yeah.
Stress is not mental stress, but physical stress you would be getting.
Yeah.
Yeah.
Yeah. Yeah. So I guess a good example is that patients who are overweight are more likely to get arthritis in the knee
Hmm. Right.
because they're stressing the knee more. The knee is unable to take the excess load that it's not designed to take because our
Right.
knees are only designed to take
For some amount of
load
weight. Yeah.
based. Yeah.
But would you then say that advising a person towards bariatric treatment or weight loss measures would and could also replace the entire part of replacing the knee itself as a procedure for arthritis or for knee
Yes.
pain?
Yes, it's quite possible because there has been a randomized trial done in Melbourne in Australia where
Mm.
they had obese patients who needed a knee replacement. So the
Right.
surgeon had booked them and said, you need to have a knee replacement.
Mm.
They took the patients and randomly divided them into two groups. And one group had bariatric surgery to
Right.
lose weight, one group
Right.
didn't. And then 12 months later, when they were due to have their knee replacement, they said, how are you going? And something like between a quarter and a third of the patients who had the bariatric surgery didn't need the knee replacement. They chose not to have it because their knee pain got better, because
Yeah.
their weight reduced.
Yeah.
So it was around a third, and it was around about 10% or so didn't need it in the non-treatment group. But the difference between the two groups was around 25%. It was around a quarter of all patients
My
didn't
goodness.
need surgery because of the bariatric surgery and the weight loss made their symptoms better.
That's fascinating.
Yeah, it is. Really is.
That's
Because we,
fascinating.
we
Yeah.
don't advise weight loss enough. Most patients who have knee replacement in Australia are overweight. And we say, oh, if you lose weight, you might not need a knee replacement. And they say, it's too hard to lose weight. Why don't you just replace my knee? And then,
Wow.
yeah,
That's
It's
again,
interesting, isn't it?
it is, it is, it is, it is, it is. I don't know if it goes to show anything. It's just good to ponder upon that this is something that
Yeah.
does happen.
Yeah.
You've written the second book called Hippocracy. it,
Hypocrisy. Yes.
yeah, but it's spelled differently. It's not
It's
spelled
spelled
as
like Hippocrates. Yeah. It's a cross between Hippocrates and hypocrisy. And so it uses the Hippocratic Oath,
Okay.
one pledge for each chapter, 10
Uh-huh.
chapters.
Yeah.
And we use that oath to show how doctors are actually doing the opposite
Of
of
treatment.
that oath. They're doing the treatments, but in doing the treatments, they're often making people worse.
Mm. But how would that be? Is it through their own way of being a doctor, or are there external pressures to behave that way?
No, it's like any profession or practice or business. People think that they're better than they really are. And so there's been studies showing that doctors overestimate the benefits and underestimate the harms of what
Mm-hmm.
they do. So doctors think that knee replacements are better than they actually are. And when you ask them about the complications of knee replacements, they tend to underplay it and underguess the harms that come from it. And so it's been widely reported that around 60% of what we do in medicine is helpful. 30% is probably not helpful, or what we call low value care. And the remaining 10% is actually harmful and makes people worse.
And this is a known thing, even by
Yeah.
doctors. Okay.
Yeah.
But again, my point would then ask is that if it is a known thing and if you have taken the pledge, what makes you behave this way? Is it
Okay. Should,
financial ROI,
yeah.
return, economic
So
value?
I'll answer the question, but first I'll rephrase it. Instead of saying well known, I should say well established, but not
Right.
widely known. And the reason why doctors still do things when they don't work, there's several factors. One, probably not the major factor, but one factor is financial incentives. So the structure of medical practice is that you get paid for what you do, and so you tend to do more of it.
Yeah.
And so it's the same thing as if you took your car in for a service and you said, I'm not sure what it needs. They're going to do more. They're going to do everything. We better just do the tires while you're here. And the brakes look a bit worn. I'll change them and they're going to do more probably than they need to. The main reason is because the doctors believe it to be effective. So there's this mismatch between the perceived effectiveness of medical procedures and the actual effectiveness. And this is this overestimation of benefit that doctors have. We think that everything we do must be helpful, and the more of it we do, the better. And so we think more medicine is better, when in fact it's not necessarily the case. And there's lots of movements that recognize this. The BMJ, British Medical Journal, has a series, I think it's called Too Much Medicine. The JAMA has a series called Less is More.
Hmm.
And these are trying to promote the idea of don't automatically assume that things work and that more things are better than less things, because that's what we do. We over investigate, we over treat, and there's a lot of waste in modern medicine.
Time as well as resources. I would say waste in time, waste in
Yeah.
resources. But this is what we're talking about is procedure the after a case has come up and you have both patient and doctor have agreed that this is the cause of the issue and then how to treat it. But what about the screening part? Do you think there is over diagnosis of things that may not require diagnosis at all?
Yeah,
Or but
definitely.
how do you come out of that? Because I can give you an example. A very close friend of mine, he had a surprise blood test And the next day at the report, the doctor comes in and he tells him that, how are you standing right now? Because your blood reports are terrible. Creatine levels are like gone to the roof and you may require kidney surgery and kidney transplant. But you're completely normal. You don't feel anything. Now, it can be a very subjective conversation to have. Maybe more blood tests required, maybe. But then if you're feeling normal, it's a very difficult thing to do and a difficult thing to diagnose. That is it really something that is problem causing? Is there really requirement to treat and proceed with treatment?
It depends on what the condition is, but screening is definitely overdone and has been associated with overdiagnosis. There was a recent publication looking at screening tests for cancer, and they calculated using large randomized controlled trials how much overall life expectancy is gained, or how many extra days, months, years of life you get from being screened compared to not being screened. And I think for prostate cancer, they found that if you get screened for prostate cancer, you live an extra 6 days or something, just like nothing. And they found for breast cancer, using mammography screening, because this has been shown before, and again, it's well established but not widely known, that the extra life expectancy from breast cancer screening is 0 days. So it does nothing to your overall life expectancy. And the way they get away with it is they measure not survival, patient survival or death, they measure death from breast cancer. And these studies show that death from breast cancer is lower if you are screened. Now think about it. That's because if you are screened, you are more likely to be diagnosed with breast cancer. And therefore, even though the same number of people are dying in both groups, the people who have been screened, it's more likely to be attributed to breast cancer because they've been diagnosed with breast cancer. Whereas if the person who wasn't diagnosed with breast cancer died, they'd say they just died of old age or something else. So there's no difference in the overall survival if you're screened or not screened for breast cancer. And that should be the test of a screening procedure, not this test of disease-specific survival, because people only care whether they're alive or dead. They tend to care a little bit less about what they die of. They just don't want to die. And so we really should be measuring mortality. So overscreening is a huge problem. And if you've got time, I can give you another great example from South Korea, where in the late 90s, they thought, oh, we're going to have a war on cancer and we're going to screen for everything. And they started screening for a lot of cancers. Now, initially, thyroid cancer wasn't one of them, but they thought, gee, it's easy to screen for because all you need to do is an ultrasound. And an ultrasound of the neck is a very easy test to get. It's not harmful. Like it doesn't involve any radiation. And so doctors started screening for thyroid cancer. And they set up clinics and people were screened en masse for thyroid cancer in South Korea over a decade. And they diagnosed a lot of people with thyroid cancer, with what's called papillary thyroid cancer, which is actually very common and not normally harmful. And so they diagnosed these and they said, oh, you need to have your thyroid removed because you've got a cancer. And a lot of people had a thyroidectomy. Now, if you have a thyroidectomy, you don't have any thyroid hormone. So you're on lifelong replacement hormones. It upsets your thyroid balance. Many people accidentally, when you take out the thyroid, you accidentally take out the parathyroid glands, which are stuck to the back of the thyroid and control your calcium metabolism. And then they were completely thrown out and they had to have different drugs to control their calcium metabolism. And sometimes when you take out the thyroid, you can upset the nerve that loops around the thyroid and goes to the vocal cords. And so you have this nerve paralysis and you lose your voice. And that happens in a certain percentage of cases. And sometimes you can die from having a thyroidectomy. So what happened was they had a record number of thyroidectomies. Thyroid cancer became the most common cancer in South Korea. It's nowhere near the most common cancer in any other country, but it was the most common cancer diagnosed in South Korea. And the number of people who died from thyroid cancer over that entire decade did not change because they did not save one life. They just caused widespread harm, cost, damage, and did not save anybody because none of the thyroid cancers detected would have killed them anyway. And that's why we don't screen for thyroid cancer.
This is not, this is a scam of a level where you have so much trust. See, that's the issue, right? Doctors are extremely learned people. They're extremely well read, researched, very experienced. Normally, that would be, if you take a trust survey between people and their doctors, it'll come up very high. The issue
Yes,
with that is that it leaves people to be over medicated and undereducated. How do you get out of
doctors,
this? Yeah.
the doctors are trusted, but I don't believe that they're very learned or very scientific. They get taught anatomy, they get taught physiology, and they get taught to treat people the way their teachers treat them. So I came out of my orthopedic training doing knee arthroscopies on people with arthritis because I thought that it helped them. I fused people's spines when they had back pain because I thought it helped them. And I believe that it did. And many of the patients came back and said they felt better. Yeah, not all of them. It must work because everybody was doing it. And I was trusted, but I wasn't very smart. I learned anatomy and physiology and I learned some techniques, but that didn't make me a great scientific thinker. I had to go away and learn that separately to learn about scientific thinking. And when I did, I realized that knee arthroscopies didn't work any better than pretending to do them, and that spine fusions probably didn't work and probably made some people worse. And so I stopped doing them. But yes, doctors are elevated in society and they're highly trusted. And I think that that can also make them complacent. It's easy to just say, I'm an orthopedic surgeon and I'm doing all the operations that everyone else is doing and I'm making a lot of money. So I'm happy. Why would you question me? No one questions me. I'm not going to question myself. And you can get complacent. And I think that's sad, but unfortunately, we need to make the medical profession more scientific and more accountable than it currently is, because at the moment, as a profession, it's self-governing.
That
There's no outside scientific body testing it. We're just testing it ourselves. And I think that's a problem, like having the software engineers testing their own
that's
code.
exactly, you are having, if you are self-governing, that is the biggest, there is no point of then having a review system if you are going to review yourself.
Yeah.
That's exactly what it is. But accountability, you said, is matched with complacency because of
But they're not
um,
being challenged. There's no reason to be more scientific. They're comfortable the way they are. And I often say in my lectures, if you got somebody from NASA or some great scientist like Richard Feynman or something to come to your hospital and look at or your research, and this is the quality of research that we're doing in medicine, I think they would have a heart attack. It's such poor quality science that we're relying on.
I was going to ask you that question, that, doubt for for the cosmos, for physics, for science is holy. Like, people look forward to doubt in their research, and so that people can pick holes and then the theory can become more
Yes. Well,
effective, or it can
yes,
be,
more robust. Yeah.
yes. But in the medical community, not in the community as such, but between patients and doctor relationships, doubt is seen as a taboo word. It is,
Yes.
i- it's, what I am saying is the right thing. If you
Yeah.
question me, then
Yes.
um,
It's a
that's a,
problem. Doubt, exactly right. Doubt can be seen as lack of knowledge. And if you say to the patient, I really don't know if this operation is going to help you or not, they'd say, well, why don't you? Like, my answer is because we haven't studied it. And that sounds terrible. And also, not treating people looks like you've a failure to care. Why won't you at least try this operation? I need something. And if I say, no, I don't want to operate, I don't think you should have an operation, they're kind of like, oh, you don't care about me, or you don't want to do the operation, or am I not paying you enough, or something? I don't know.
Maybe medicine is more personal than the cosmos and the universe, and maybe that is why it gets a more biased view. Or
Yeah, there is it's an interpersonal relationship that you have with the patient, and I think that clouds things a bit.
yeah,
I
like
think that's a good observation.
you cannot have a neutral perspective for something you're attached
Yeah,
to, not in terms of physical attachment or emotional attachment, but just it's your own human body as well.
yeah, yeah.
If
There's a lot of drivers in the the structure of medical practice that drive us towards doing things, away from not doing things is seen as failure, or it's seen as an inadequacy, or you're not good enough. Not doing things doesn't pay you. Often the hospital that you work at wants you to do things because that's how the hospital gets paid. That's how
yeah,
you get paid. That's how the device manufacturer gets paid. The patient wants to get something done. The patient's relatives want them to get something done. Often patients' relatives will say, just go and do it. You need to get fixed. And so that all the incentives are towards doing things rather than being simply
waiting and
rational.
watching. Yeah, maybe.
Yeah.
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 Yeah, it's very interesting. It actually makes you think, and hopefully makes you think that what should the questions be asked then from a doctor who prescribes surgery?
Yeah.
Like if I'm a patient tomorrow and somebody tells me that I need to replace my knee or I need to get this surgery done, as a patient, what should be the questions next that I should ask so that I can be on the righter side of things?
Yeah, that's very important for patients to know. So the questions I tell patients to ask their doctor, and the question I have used when I've been in the patient side of the equation is, what evidence do you have that doing this operation is better than not doing this operation? And what is the quality of that evidence? And if they say, I find that a lot of patients get better, that's not good evidence. But if they say they have done a randomized trial where the patients who had the operation had 30% less pain than the patients who didn't have the operation, or something like that, then that's evidence that it's effective. So you can ask them for the evidence, or you can simply say, what's the advantage of me having this operation compared to not having this operation? And what's the disadvantage of having the operation? So what are the risks and benefits compared to not having it? Because you've got to look at the counterfactual. You've got to look at the opposite side of the equation. And too often people get caught up with the operation and they say, okay, what's the success rate of the operation? And the surgeon will say, oh, it's 70%. Oh, what's the risk of a bad complication? Maybe 5%. Okay. And they weigh up 70 against 5. And they think, okay, that's pretty good odds. I think I'll go for the operation. That's not the question they should be asking. They should be saying, okay, it's 70% benefit, 5% harm. Okay, thank you. Now, what's the risk and the benefit if I do not have the operation? And then the surgeon may say, you've got maybe a 60% chance of getting better and a 0% chance of harms. And then it's, oh, okay, now I can see this is a line ball. This is not so clear. And take into the account then that I have to pay money for this operation that may only have a very small chance of making me better than if I don't have it, I'm going to have maybe second thoughts.
My
So you've
God.
got to compare it to not doing it, or a reasonable alternative, a brace, physical therapy, or an injection, or whatever the alternatives are for that particular condition.
Or take second opinions or third opinions as well.
Yeah. And don't be afraid to get a second opinion, because doctors actually don't mind. It's very common to get a second opinion. And if the doctor is confident in what they're doing and it is reasonably straightforward, then the second opinion will say the same thing. And it
Yes.
will only reinforce that
Yes.
treatment and make the patient more comfortable about progressing. I have no problem recommending second or third opinions to patients because it's good for them as well.
Yeah. It's just that when you ask doctors for questions, or when you ask the benefit of doing something versus not doing something, it becomes an ego risk in terms of how can you question me? The doubt part, as we
It
spoke
shouldn't
about.
be.
Yeah.
It shouldn't be. Doctors
Yeah.
really should be. And now, and I know that this kind of thing varies between cultures a lot. So I
Right.
think in some, I've lectured widely and taught surgeons all over the world, and the culture certainly plays a role. And I have very great stories of doing lots of lectures and tutorials and courses in India and
Okay.
many in China and other countries. And to give you an example, in China, I will stand there and give an opinion and say this, and the audience will not say anything. Even in a small tutorial, they won't challenge you or anything like that. But in fact, it's so difficult, I stopped doing courses in China. But I did courses in India for a long time because it's lively and the
It,
doctors there have no problems. They're just saying, oh, what about this? And what? They're asking questions and they're
right.
challenging you. And it's very
Provoking as
open.
well. Yes.
Yeah, very open and lively. And it's encouraging to see that kind of thing. It's very discouraging to see a society where nobody questions
Right.
or they're afraid to question or it's impolite to question. Now, I think it's probably different. That's fellow surgeons with another surgeon. And
Yeah.
I think when it gets to patients and
Yeah.
doctors, it's a different dynamic. And I think, yes, some doctors feel like the patients shouldn't question them, and some patients feel like they shouldn't question the doctor. But I can tell you the good doctors, the doctors who are comfortable, who are confident, who know what they're doing will not be challenged by a patient who asks them a reasonable question about whether the treatment is better than not doing the treatment and what the relative risks and benefits are of that treatment that they're suggesting.
Right.
No doctor should ever take offense at that.
You said that most of when you went through college and when you went through your surgical ways of doing things and first 7 years and first 10 years that you were implementing surgery, the way you did it was that you had seen and you were taught the way to do it.
Yes.
And it was more as a systemic thing of performance of surgery based on things as the textbook would say.
Yeah.
Like
We
you're not
constantly,
applying your own, you're not discovering the process, you're not you're not inventing anything new. You're essentially doing something that is taught to you. Can restraint be taught as well? Do you-
yeah, that's what I try to do. Yeah. And I think there's too much of a focus on the technical aspects. And so spine fusion surgery is a good example where surgeons have endless debates and meetings and conferences where they discuss the technical differences and ways that you can do a fusion. And they very rarely ask whether we should do the fusion or not do the fusion.
yeah.
Teaching restraint. Yeah, so I try and educate doctors that doing nothing is reasonable. Waiting is sometimes reasonable, and it's not a sign that you're failing to treat.
See, there are these the army, the navy, military people, commandos, special forces. They go through a crazy amounts of work and excessive wear and tear of their entire bodies, and they're subjected to crazy conditions where and they've built their bodies to sustain crazy scenarios which are not bearable for the average person doing an average job. Or my point is that how are their physiques different from ours, and they have maybe mastered strategies where they cannot perform surgeries on the field if they get injured. They cannot, but they have those techniques of being okay, or being your training your body to be resilient and resistant of not requiring external medicine because you are trained that way to be. My question is that the body is malleable, flexible, and strong on its own to take care of itself. And the natural, as you said in like earlier, that natural history is something that we don't really take into account before. We don't wait for it to heal on its own.
Yeah. We are very resilient. The human body is amazing. And mentally and physically, we're losing our resilience and we have an over reliance on external input from usually doctors. And this is a phenomenon called medicalization, where so many things have become you need to see a doctor before you can get better. And so many things get better on their own. There's famous stories of people who thought that medicine was important and found that it really isn't. And one of the best stories is from Archie Cochrane, after whom the Cochrane collaboration is named a big source of evidence-based medicine. But
Mhm.
he was captured he was in the British Army in World War II, and he was captured by the Germans. And he was in charge of some 10,000 or more prisoners. And he was the only person with any medical training. And they had no medicine. And I think it was 20,000 men.
Mm.
And he thought, oh, they're all going to die because they had wounds, they had dysentery and infections, and he said to his German captors, "We need doctors. This is not fair. We can't survive without medicine, without doctors." And the German captors said that doctors are superfluous, and they got no medical treatment whatsoever. And after 6 months in captivity, out of those, I think it was 20,000 men, 4 died. 3 of them died being shot trying to escape. And he was absolutely amazed that all these men with wounds and injuries and infections and diarrhea and things got better. They just got
Yeah.
better without any medical treatment at all. And that's what started him when he came back after the war to England. He started questioning a lot of the treatments. And this led to the first randomized trials in medicine. And so, for example, if you had a heart attack in the 1950s in Britain, you were put on bed rest for a week.
Right.
And they did that because they didn't want to stress the heart after
Right.
you had a heart attack. And it makes sense. And because they did that, most of the people who had a heart attack didn't die. And they assumed that they didn't die because they had bed rest for a week.
Yeah.
But of course, they didn't know what would happen if they didn't have bed rest. And so he challenged this, and they said, "Oh, you can't do that. You'll be killing all these people. Their hearts won't take it." And he got these people just mobilizing straight away instead of being in bed rest, and found that they actually did better. And the bed rest was harmful. So we just assume that these things work because we are like the water diviners finding water.
Yeah, because we think that correlation of and
Is
adding up of
causation.
yes,
Yeah,
it is. But that's unfortunately how herd mentality works. That's unfortunately how
that's
it.
that's
Yeah,
how humans work. It's not how
yeah.
scientists work. Yeah.
That should not be how scientists work. And also, I think this is a trainable way of thinking, hopefully, not to get attached to popular thinking versus having your own view.
Yeah.
That
Yes.
should be, but also, as you said, depends on culture. China is not as your experience in China was not as great, but then the neighboring countries were more challenging. See, drugs to be approved anywhere, they have regulations and regulatory bodies. The United States has FDA. India has its own regulatory body to approve any new drug. I think it's called CDSCO, Center for Drug Control. Anyway, is there any regulatory body to approve surgeries and the way surgeries are performed?
Yes and no, not in the same way as drugs.
And should there
So
be? Yeah.
yes, they should. So new operations are introduced without randomized controlled trial evidence, and they become commonplace until somebody comes along and does a randomized controlled trial, perhaps 20 years later, showing that it doesn't work. And so it certainly should be. However, if you were to introduce a new procedure and want to have it reimbursed by the government in Australia, you would have to show very high level evidence similar to a drug. The problem is that nearly all of the operations we do were put on that list based on the fact that they are the operations that we do. So that list of drugs that are reimbursed by the government was created around 1985. And when they created that list, they tested nothing. They just put every operation that was commonly in place on the list. So now, if you want to add a new operation, then it has to go through a proper testing process. But nobody's testing the operations that are already on the list.
They're all grandfathered and
Yes. Yeah. And I've argued with the government. I said we should be doing the same test for procedures that are already on the list as we demand for new procedures that want to be on the list. It should be the same rule. And they said, there's too many. It would take too long. And I said, okay, then test one of them and then test another one. It's
yeah.
still better than testing none of them, which is what we're
Right.
doing now.
Do you think AI or automation of tasks or processes in any way would benefit both
Perhaps in the
parties?
decision making. Yeah, in the decision making, not in the conduct. We use robotics and things,
Yes.
but that's never been shown to make actually any difference, because for the same reason that a table built by a carpenter is not inferior to a table built by a factory
Yeah.
with a robot. So it's not difficult to cut bones and insert screws.
Yeah.
You can have a robot do it, but it doesn't make it any better.
Yeah.
But the decision making, I think, can be changed, because we make decisions that are heavily influenced by our humanness. And the last complication that we had, or the last patient we treated with that condition who was very happy, we tend to be influenced by that, and it's not very scientific. And I think we can have a much better scientific approach if we input all of the evidence and say, what's the most likely diagnosis in this case? And what
Right.
is the best treatment for this patient?
So
We
AI
could
would give us,
automate, yeah, AI would give a better answer almost every
would
time.
give
I
us a
think.
more neutral answer. There is no emotion and bias
Yes.
that, or the memory of where does it work versus where does it not work and who is more happier.
Yeah,
Yeah.
exactly.
Makes a lot of sense. I have one last question to you for you. This is not anything related to your background or your niche or anybody's background. This is like a very common question that I ask. Two actually. One is that why do you do what you do? And why is it that you have so much conviction? And it's not like you're the only one. There are some like you, but not a lot. But you still have a lot of conviction. So where do you get the conviction from, and what do you think is your purpose of life?
I get the conviction the same way I got the conviction when I first saw that documentary, because I'm convinced that the scientific method is the least biased way of
Yeah.
determining effectiveness or determining an answer. And it is the least biased way because the scientific method is merely a method of bias reduction. That's all it is.
Yes.
It's just a simple,
Really.
you minimize bias. That's all science tells you to do. And so it makes rational sense. And so that's where I get my conviction from. But what drives me to keep doing this kind of stuff is because I want things to be based on the truth. And the best estimate of the truth is the scientific estimate, or the least biased estimate. And so I don't want people to have operations that don't work. I don't want society to waste money and cause harms to people by doing unnecessary procedures. And I want medicine to be the kind of science that rocket science or physics is, and it isn't. at the moment, but it can be.
Dr. Ian, thank you so much for your time. That is, I think, truth seeking is something that is not taught, or maybe even if it is taught, we get sidelined with our ambitions of material good. And why shouldn't we? Would be a good argument to make by somebody who thinks that is okay. But we all have our convictions to do.
Yeah.
And I think being truth seeking as your foundational principle makes you who you are and makes you that convinced to doing what you do. And I think that's crazy. I think more yeah.
I think everybody wants to seek the truth, but they're not necessarily using the right methods. They're using their own human emotions and biases and not using the least biased method of determining the truth.
Right.
So everybody's well intentioned, but they're influenced by things and sometimes not aware of it.
On that note, Dr. Ian, thank you so much for your time. It was a pleasure speaking to you. I think if we can, do you think you'll be writing another book anytime soon?
Probably not. I'll probably be retiring in a few years.
And then doing what?
Woodworking.
Wow, that's nice. You'll be giving up clinical research?
Yeah, I think I've got another 5 or 10 years left in me of research, probably.
All
Yeah.
right. I hope that you do what you think is best for you. But at the same time, I hope that there is a saying in India that doctors never retire.
Yeah,
Um,
it's a bit like that here too.
yeah. I am of the opinion that like I'm very young right now and I have a lot of fire going and I have a lot of things going. But I hope that people don't retire from doing what they're doing. Like they should do more of what they really like doing. So woodwork
Yeah.
for sure.
I still enjoy doing my work, so I won't retire while I still enjoy it. Yeah,
Awesome. Awesome. Awesome.
yeah.
On that note, thank you so much for your time, doctor. It was a pleasure. I will send you a link once this is ready.
Please.
I do
Yeah,
edit.
that'll be
And
great.
yeah, I will. Yeah, let me know if there's anything that you wish to say. And I hope we keep in touch and we'll have another one sooner than later where we talk more
Okay.
about surgery and I'll do maybe more research. It was fascinating talking to you. Would love to get on a call sometime, some other time, whenever you're free.
My pleasure.
Thank you so much.
Bye-bye.
Bye-bye.
Bye.
Take care. Yeah. Thank you so much for tuning in, you guys. If you like this, then you can hit the like button. The algorithm likes it, gives me more views, and maybe I can contemplate on keeping this channel for free for you to see. If you hit the subscribe button, the algorithm likes that as well. But unlike the like button, this is more useful because you'd be actually notified by every time we do drop a video on this channel. If you have any complaints regarding the content that we drop or the questions that we ask or you want to give us any suggestions with questions or people that you want us to interview, we have added a feedback form in the description. You are very welcome to fill that up and let me know. If you hated this content and you do not want to see my face ever again and do not want to share it with anybody and do not want to refer this kind of content with anyone, then until you do tune in to my next episode or my last episode, or you do tune in, I would like to wish you in Truman Burbank's very own words, good afternoon, good evening, and good night. Cheers.